chapter of the Sigma Nursing Honor Society, which is called Pi Mu. So the free lunch you guys get later today is paid for by Pi Mu. Just a reminder for nursing students, you will sign in and sign out using these QR codes that will be posted before and after each presentation. So make sure that you are signing in for each of the 3 presentations. If something isn't working with your device, there is a paper form you can fill out with Sam just outside the doors. And without further ado, I am extra excited because today for our welcome, we have Reverend Dr. Shannon Dykes joining us. So if you would all please join me in a big round of applause.
It's like which podium to use. Good morning. Thank you, Dr. Clark, for this invitation. I was just saying, I've been at EMU for a while, new to this role, and I didn't know wonderful things like this happened on campus. And so I'm excited to be able to celebrate with you all the great work that you've done. So good morning, my name is Shannon Dykes. I'm president here at EMU, and it's a joy to join you in this Scholarship Day, an event that really reflects the heart of who we are at EMU. You all are scholars who care deeply. You are practitioners who lead with wisdom. You're people who are committed to transforming communities through compassionate, evidence-based practice. So to our nursing students, especially those seniors who are presenting your work today, congratulations. This is a moment not just about a requirement for your academic checklist. This is a celebration of the scholar that you have become. Today, we see you not only as caregivers, but also as investigators of truth, interpreters of data, bridge builders between research and real human lives. Nursing is a discipline that allows this to happen, that allows you all to connect science and service, where you allow evidence and empathy to meet each other, where the smallest clinical decisions can alter the arc of someone's life. And so your scholarship, your ability to ask questions, to test assumptions, to learn from community partners, and to act upon research, all of that shapes the kind of nurses our world needs most. This year's conversations, presentations, prioritize this in very real ways, paying attention to urgent needs in population health. You all will speak to presentations where evidence-based nursing can shape better outcomes for very vulnerable populations, supporting safe prenatal and postpartum care, providing dignified mental health treatment for individuals with intellectual disabilities, guiding families through childhood obesity with empowering and stigma-free strategies. These are the complex human challenges that require more than procedures. They require insight, and courage and advocacy. The work that you will share today represents months and maybe even years of engagement and learning, your connection with local agencies, and you didn't do this by simply reading books. You listened, you collaborated, and you responded. This is who we are. This is who EMU is at its best. Learning that gathers information in service to other people, scholarship that integrates what we've learned and uplifts other people, and evidence that becomes love in action. So congratulations and thank you for who you are and who you are becoming. To our faculty who have mentored these students, thank you. You have demanded rigor while nurturing resilience. You have taught the science of nursing while also modeling the soul of it. To families, friends, community partners who are here or watching live, we are grateful for your support. We don't arrive at moments like this alone. We carry the encouragement, the sacrifices, and the trust of people in our families and in our communities with us, and so we offer gratitude there as well. To each of you students, let today be more than just presentations. Let it be a reminder that you are entering a profession where knowledge is not static, where it is growing, where it requires questions, adaptations, and advocacy. The world expects you to be competent. We expect you to be compassionate, and people are waiting for you with wisdom, justice, and care that you are carrying within you. Congratulations. Thank you for the passion you bring, for the scholarship you bring, for the questions you ask, and the hope that you carry. Thank you for being EMU. Thank you for showing us how to live it out in real life. Let's celebrate today with learning and conversation, and welcome today to this day of celebration.
Thank you so much, Dr. Dykes, for those words of inspiration and acknowledgement. And without further ado, my name is Holly Hurst-Travers, and I've had the privilege of being one of the faculty instructors for the Population Health Colloquium course. And I would like to introduce the first presentation, it is entitled, A Bump in the Road, Postnatal Outcomes of Little to No Prenatal Education. And I'd like to invite our presenters, Caitlin Custis, Caitlin Liskey, Taylor Mackerel, and Riley Yoder. Thank you.
Good morning, and thank you for being here. My name is Riley, and presenting with me today are
Taylor,
Caitlin,
and Caitlin.
Today we'll be presenting our project, A Bump in the Road, Postpartum Outcomes of Little to No Prenatal Education.
So before we dive into the details of our project, this slide just gives a quick overview of everything that we'll be covering today. We're going to start by defining what prenatal education actually includes, not just classes about childbirth, but also preparation for breastfeeding, postpartum recovery, newborn care, and the emotional transitions that come with becoming a parent. Next, we'll look at what the research shows, including how insufficient prenatal education can increase risks for postpartum complications such as breastfeeding difficulties, higher anxiety and depression, and even increased emergency department visits. We'll also connect this to our local context here in Harrisonburg and Rockingham County, where barriers like limited resources, language differences, and inconsistent access to programs make it harder for families, especially those vulnerable populations, to receive the support that they need. And from there, we'll explore nursing and healthcare interventions and discuss possible solutions that can help increase access to education and improve outcomes for mothers and infants. And finally, we'll highlight gaps in the research, focusing on areas where more information is needed to better support families in the prenatal and postpartum periods.
Before we share with you what our definition of prenatal education is, we want to hear from you guys. So chat for a couple minutes and come up with your own definition of what you believe prenatal education is or what that may include.
Was it fast? Oh, sure. Oh.
30 more seconds. We have 15 seconds. 15 seconds.
Are you going to say 10 more seconds?
No.
Do you want to say like 10 more seconds?
5, 4, 3.
Okay.
Yeah, she's
All right. So, any answers from the crowd?
If you answer, you get some candy. Hope this helps. Okay. Emily.
Just a minute. We said prenatal education is education that someone receives before they get pregnant or while they're pregnant.
Perfect. Just one more.
All right, so based on our research, prenatal education serves as a structured approach to preparing pregnant individuals by addressing key topics such as breastfeeding, postpartum depression, birth-related fears and anxiety, potential postpartum complications, and anticipated postpartum lifestyle adjustments. This education may be delivered through individual or group classes or integrated into routine prenatal and postpartum appointments. The critical component is ensuring that information is presented clearly, delivered at an appropriate pace, and provided when the individual is mentally well and able to fully engage with and comprehend the material.
Keeping in mind what prenatal education is, we are now going to look at the research. We reviewed multiple studies that examined differences in postpartum outcomes depending on whether mothers received no prenatal education, minimal prenatal education, or comprehensive education. Unfortunately, we were not able to find a lot of local resources surrounding this data, so we do have a couple of resources that were conducted, or studies that were conducted outside of the US. But from these studies, we will be specifically looking at how prenatal education affects outcomes of the mother and baby, psychological outcomes, and overall negative outcomes when education isn't received or isn't effective.
This slide focuses on how prenatal education directly impacts both maternal and infant outcomes. Research consistently shows that when mothers participate in childbirth education, they have better experiences and better health outcomes after delivery. For example, a study by Vanderlyn and colleagues in 2023 found that mothers who attend prenatal classes were more likely to return for their postpartum visits, begin using contraception after birth, follow safe infant sleep practices, and start and continue breastfeeding. Similarly, Mueller and colleagues reported that mothers who took structured childbirth classes were less likely to have labor inductions, use pain medications less often, and were more successful with breastfeeding without needing additional formula. These findings show that prenatal education increases confidence, preparedness, and positive decision-making during the postpartum period.
So, building on those findings that Riley just talked about, research also shows that multi-session classes provide even greater benefits than single-session programs do. A study by Vanderlyn and colleagues in 2021 found that attending 3 or more childbirth education sessions significantly reduced the likelihood of a planned C-section, lowered the use of pain medication during labor, and increased shared decision-making between mothers and their healthcare providers. So what's important is that even just attending one session led to measurable improvements, which highlights the value of consistent and structured prenatal education. In addition to individual classes, group-based prenatal education can strengthen outcomes even further. Avalos and colleagues in 2024 examined group multimodal prenatal care, also known as GMPC, it'll be up on the slide sometimes, and found that women who participated in these group sessions reported better psychosocial well-being, stronger social support, and a higher perceived quality of prenatal care. These programs create a supportive environment where women can learn together, share experiences, and build confidence as they prepare for childbirth and the postpartum period. So taken together, these studies show that prenatal education is most effective when it is structured, multi-session, and offered in very supportive formats. These approaches not only improve physical outcomes like reduced interventions and better breastfeeding success, but it also enhances emotional well-being and helps mothers feel more prepared as they enter the postpartum phase.
In this part of the literature that we researched, these particular studies looked at how prenatal education impacts the psychological outcomes of mothers. Kankaya and Simsek did a study looking at the positive impacts of when there is structured prenatal education. More specifically, they looked at the effects of prenatal education on birth fear, depression, anxiety, stress, childbirth, self-efficacy, and mode of delivery in first-time pregnant women. This was a single-blind, pre- and post-test randomized control trial done in Turkey's Central Anatolia region. The study included 120 first-time pregnant women who were randomly assigned to either the prenatal education group or the control group. The prenatal education group participants attended 2-hour sessions twice a week for 4 weeks. The sessions included topics such as labor process, managing pain, postpartum care, and coping strategies. The researchers discovered significant differences between the prenatal education group and the control group. Those in the education group were found to have less overall birth fear, depression, anxiety, and stress symptoms, as well as increased childbirth self-efficacy compared to the controls. Additionally, there were more vaginal births that occurred in the prenatal education group versus our control group. Zhao and colleagues conducted a randomized single-blind controlled trial design, and they evaluated the effectiveness of prenatal intervention on breastfeeding, maternal physical well-being, and maternal psychological well-being at 3 days postpartum. There was a sample size of 182 first-time pregnant women in Shanghai, China. The women in the study used the Edinburgh Postnatal Depression Scale, and if their score was 9 or more, they were randomly chosen to be in the intervention group or the control group. 91 women participated in 4 sessions that promoted management of breastfeeding, physical well-being, and psychological well-being. The control group also included 91 women, and these women received usual care without any additional individual management. Zhao and colleagues found that the intervention group had significantly more effective breastfeeding, lower Edinburgh postnatal depression scale scores, more sleep, and a better appetite compared to the control group. Together, these studies demonstrate that structured prenatal education, whether focused on childbirth preparation, mental health, or breastfeeding support, plays a critical role in helping mothers feel informed, capable, and emotionally resilient during pregnancy and early postpartum period.
When prenatal education is not effective, mothers have the potential to experience negative outcomes both physically and mentally. These studies show how ineffective prenatal education can lead to increased reporting of anxiety, depression, and increased use of the emergency room. In 2021, you and colleagues conducted a study in South Korea that looked at the prevalence of depression among the women and their spouses at 6 different time points during pregnancy and postpartum. This data collection occurred over the course of 2 years. You and colleagues discovered that women with minimal prenatal education or poor preparation for childbirth had significantly higher rates of postpartum depression and anxiety. Postpartum depression was influenced by lower self-esteem, having experienced prenatal depression or anxiety, lower social support, lower marital satisfaction, and higher life stress. The study showed that the prevalence and factors that affect maternal depression changed over time and emphasized that mothers need to be screened periodically throughout the postpartum period. Adding on to this research, in 2020, Patel and colleagues conducted a retrospective review of hospital records from 2015 to 2019. This study took place within the University of Texas Southwestern Medical Center and kept track of all postpartum hospital encounters within the postpartum period, which is 6 weeks. The purpose of this study was to describe trends in postpartum emergency room visits and hospital readmissions by analyzing the chief complaints and admission diagnoses. There were a total of 8,589 deliveries, and out of these deliveries, 491 people presented to the emergency department, resulting in 224 hospital admissions. Over the course of the study, admission rates rose from 2% to 3.4%. The women coming to the emergency department presented with symptoms of fever, abdominal pain, headache, vaginal bleeding, wound concerns, and high blood pressure, which then led to admitting diagnoses of hypertensive disorders, wound complications, endometriitis, and delayed postpartum hemorrhage. Together, these 2 studies show that when prenatal education is lacking, mothers are more likely to experience negative mental health outcomes, as well as increased physical complications and hospital utilization. This highlights the critical importance of structured, effective prenatal education in supporting both maternal mental and physical well-being. This semester, we partnered with Huga Wellness. Huga is a local healthcare office that does a lot for our community. The word Huga itself is a Danish word that means comfort, safety, and togetherness. The clinic strives to incorporate these values into the care that they provide. Huga's mission is to provide individualized, holistic, and evidence-based maternity and family health care. They serve women of reproductive age, pregnant people, newborns, and families. Huga has had approximately 35 births per month, and by the end of November, they will have had 385 postpartum visits approximately in this year alone. When we partnered with Huga, the provider shared with us that they needed more educational resources, primarily focusing on postpartum education. A couple examples of the handouts that we created were gestational diabetes postpartum screening recommendations, postpartum healthy lifestyle behavioral advice, tobacco use screening and cessation education, and immunization review and updates. We partnered with Huga and made handouts for them to share with their patients online and printed.
Next, we wanted to look at what this issue means in our own community, specifically Harrisonburg and Rockingham County. When we step back and look at the local data, we can see several real-world barriers that affect access to prenatal health care. The first major barrier is language. Harrisonburg Public Schools report that families speak over 55 different languages at home. That number is huge, and it reflects how diverse our community really is. But it also means that many patients may struggle to understand printed health information, communicate with providers, or even schedule appointments if services aren't offered in their preferred language. If someone can't fully understand education materials or instructions, the quality of their prenatal care can be significantly affected. Another major challenge is transportation. In Rockingham County, about 5.6% of households do not have a vehicle, and almost 21% only have one car. For many families, that one car might already be used for work, school drop-offs, or other responsibilities. So something as simple as getting to a prenatal appointment, a childbirth class, or a postpartum follow-up can become a serious logistical challenge. Transportation shouldn't be the reason someone misses essential care, but unfortunately it often is. The third barrier we see is healthcare costs. Even with insurance, many families in Virginia still afford co-pays, specialty services, medication, or time off work. When finances are tight, preventative and educational services, like prenatal classes, can easily fall to the bottom of the priority list. So when we look at language diversity, transportation limitations, and financial barriers together, it becomes clear why community-based and accessible prenatal education is so important. If we want to improve outcomes, we have to meet people where they are, culturally, financially, and geographically. Understanding these local barriers helps guide how programs should be designed to support real families living right here in our community.
In addition to our identified local barriers, research has explored the obstacles patients and providers encounter in their experiences. From the provider perspective, Vanny and colleagues in 2025 found several barriers to delivering adequate postpartum education. These included complex social needs of patients, mistrust of the healthcare system, traumatic birth experiences, poor communication between clinics, limited appointment time, and educational materials that were difficult to understand. Two powerful statements noted in the study included one from a high-risk obstetrician who noted that, quote, patients are really afraid that people are going to see them as unfit mothers and that they're going to call Child Protective Services, and so they would not engage with mental health care because they are worried, unquote. A lactational consultant emphasized the power of consistent support and said, quote, at a time when patients' attention might be so divided between worry, desperation, fear, grief, and their own health, having really consistent, almost relentless, warm support might make the difference between their life and death, unquote. On the other hand, Adams and colleagues focused on patient perspectives. They found that women often misunderstand normal postpartum recovery and aren't adequately prepared for common complications such as hemorrhage, infection, or postpartum depression. Education was often delivered at times when mothers were already overwhelmed, which made it hard to retain important information. Negative healthcare experiences also contributed to mistrust, which can prevent women from seeking care when they truly need it. Quotes from the participants included things about speaking about barriers in obtaining care for themselves. One participant said, quote, as for the challenges, they are plenty. You may come to meet a nurse with hot temper, and the utterance alone will scare you, and anytime you want to come here, you are worried, unquote. Another stated, quote, if you deliver through surgery, you simply cannot forget it, unquote. These studies reveal real-world experiences of individuals facing a multitude of barriers. By addressing these barriers and improving education, healthcare teams can better support new mothers, prevent complications, promote confident, healthy transitions into the postpartum period.
Now we want to highlight key nursing interventions that make prenatal education effective. First is group multimodal prenatal care, or GMPC. This was previously mentioned in our research written by Avalos and colleagues. So this model combines healthcare, education, and peer support, giving pregnant women a holistic environment to learn and connect. Studies show that women who participate in GMPC report higher confidence in caring for their newborns, greater success with breastfeeding, and lower anxiety and stress during the postpartum period. Another important strategy, which was outlined in our research by Vanderlyn and colleagues, Mueller and colleagues, and Kinkaya and Simsek, is standardized curriculum. Providing consistent, evidence-based information ensures that all patients receive accurate guidance on labor, delivery, and postpartum care. Multi-session programs, whether in person or online, allow women to engage with the material at their own pace and accommodate different learning styles and literacy levels. Research indicates that structured curriculum, especially when combined with multiple sessions, reduces labor interventions, improves decision-making during childbirth, and enhances maternal confidence. Finally, another important evidence-based strategy is centering pregnancy classes. Centering pregnancy is prenatal care in the form of a group setting. In centering pregnancy groups, pregnant people who are due around the same time get the space to be with other pregnant women and share experiences. Centering groups open a safe space for pregnant women to bond, talk about pregnancy, childbirth, family, and parenting. The information covered at each session is up to the women. Centering pregnancy is very patient-centered and is proven to reduce preterm birth rates. Overall, these 3 nursing interventions address both the educational and emotional needs of pregnant women. These evidence-based interventions can work to improve both physical and psychological outcomes for the mother and baby. Next, we would like to show you all an example of centering pregnancy and how evidence-based care can improve overall outcomes for mothers, spouses, and babies.
Centering Pregnancy is a national organization, and Centering Pregnancy is a trademark curriculum for prenatal care. It is the only thing that in decades has been shown to reduce the preterm birth rate. There is a curriculum that we certainly want to cover with each session, but the way that all happens is guided by what comes out of the group, what's important to the women in each session. The beauty of Centering is that it's stable, and every time you come, you'll always have the same provider. And the facilitator also stays the same. So the members stay the same, and 2 clinicians and members stay the same each time. You're able to develop a relationship. You're not starting from square one every time you go into a very abbreviated appointment. It starts out as being a once-monthly appointment, and then as you all get closer to our due dates, it switches to twice monthly. And we all start out by coming in, getting a little bit of health check. We have our weights taken, blood pressure, belly checks. We have the health metric, make sure baby's growing properly. And then we'll just kind of sit around in a circle and chit-chat. It's truly a clinical picture. And it's another way to get their prenatal care instead of going to the clinic and having a short appointment. It's truly their 2 hours. We knew we wanted to participate in the summer program because of the philosophy of it, which is essentially to go through the pregnancy experience with similarly situated
Okay, now that we have a deeper understanding of centering pregnancy and other forms of prenatal education, we'd like to take a quick poll with you guys. So our question is, would you prefer to have individual prenatal care or group prenatal care? So I'm gonna have you all stand up, get some blood flowing. So if you would vote to have individual prenatal care, please stand up. Okay, so now if you'd rather have group prenatal care, stand up. Yay! Everybody stands. Okay, go ahead and stretch, get some wiggles. You can sit back down whenever you're ready. Okay. What influenced you all to pick group, since no one picked individual? Anybody? Any takers? Leah. It looks more fun. Okay, cool. Looks more fun. Anybody else? Okay, that's so valid. Oh, can you give them candy? Sorry. Thank you. You guys get candy. Don't worry, it's on the way. Okay. Thank you all for your participation.
Okay, so one evidence-based solution supported strongly by the research is, like we talked about earlier, the implementation of structured multi-session prenatal education programs that are tailored to the needs of the local population. Studies show that when education is spread out over several sessions rather than delivered in a single session, mothers experience clear benefits from it. Previously mentioned Vanderlyn and colleagues in 2021, it demonstrates that multi-session programs enhance shared decision-making during childbirth and reduce the likelihood of relying on pain medication during labor. Similarly, Avalos and colleagues in 2024 found that consistent, repeated sessions, especially in supportive group settings, improve maternal confidence, breastfeeding success, and overall mental well-being. By providing ongoing evidence-based education across multiple sessions, these mothers are better prepared for labor, delivery, and postpartum recovery. These programs give women the time and space to build knowledge, ask questions, improve self-efficacy, practice new skills, and develop confidence as they transition into early parenthood. Ultimately, this structure reduces preventable complications and leads to stronger postpartum outcomes. So this next slide just kind of sets the stage for the next two sections of our presentation, where we connect our project directly to nursing practice. And to do that, we're going to look at two key frameworks, change theory, which we learn about in level 3, and the sacred covenant of nursing. That's kind of the foundation for nursing here at EMU. First, we'll connect our work to the sacred covenant, which emphasizes the nurse's responsibility to provide compassionate, evidence-based care that supports families through major life transitions. Prenatal education fits directly within this commitment because it empowers mothers, strengthens trust, and reduces preventable harm to patients. Next, we'll walk through how change theory helps explain why structured prenatal education can create meaningful improvements in maternal and infant outcomes, and what steps nurses can take to support those changes effectively. These two frameworks help show not only why our project matters, but also how it aligns with the core values and responsibilities of nursing practice. And we'll explore each of them in more detail in the next slides.
The sacred covenant guides how we approach care in a way that is relational, respectful, and grounded in dignity. When we apply it to prenatal education, several elements stand out. First, empowerment and partnership. Prenatal education is not just about giving women information. It is about helping them feel confident and capable in making decisions about their bodies and their birth experience. Instead of the nurse being the expert who talks at the patient, the sacred covenant emphasizes a co-partner relationship. Women bring their own experiences, knowledge, culture, and values, and we work alongside them. When prenatal care is taught this way, patients feel more ownership over their pregnancy and are better prepared for birth and postpartum. Next is justice and advocacy. We know there are major disparities in which women receive quality prenatal education. Some communities have classes available, transportation, childcare, or insurance coverage, and some don't. Justice means recognizing that gap and working to close it. Advocacy means helping women navigate barriers, whether that's understanding resources, connecting to classes, or being supported in the healthcare system. When we apply advocacy intentionally, we start reducing preventable differences in outcomes. Finally, grace. Pregnancy and postpartum are huge transitions. Women can feel overwhelmed, scared, exhausted, or unsure of what to expect. The Sacred Covenant calls nurses to provide support with patience, humility, and understanding. Sometimes this looks like taking extra time to explain a teaching point, offering emotional reassurance, or simply being fully present in a moment where someone needs to feel heard. Grace recognizes that learning and adapting take time, and it helps build trust. Together, these Sacred Covenant elements, empowerment, partnership, justice, advocacy, and grace, shape prenatal education into something more than teaching. They turn it into a relationship that supports the whole person and contributes to better outcomes for mothers and babies.
So here we have Lewin's change theory, which includes 3 stages: unfreezing, moving, and refreezing. In unfreezing, recognizing that change is needed, breaking down old habits or ineffective practices. The moving phase includes implementing new processes, behaviors, or interventions. And the refreezing phase is solidifying the new practice so it becomes the new standard. For our project, Unfreezing, our goal is to increase prenatal education, and the issue is limited education in the Harrisonburg-Rockingham area. In the moving phase, new strategies would be implemented, such as standardized teaching tools, better communication between clinics, personalized education for high-risk mothers, and group or individualized classes. In the refreezing phase, these improved educational practices are reinforced and integrated into routine postpartum care. This ensures long-term consistency, better maternal understanding, and improved postpartum outcomes.
So, gaps in the research. While there is strong evidence supporting the benefits of prenatal education, there are still important gaps in the research that need to be addressed. The first one we notice, much of the existing research focuses on urban populations or larger healthcare systems, so there's limited data on rural communities like Rockingham County. This means that we don't fully understand the unique barriers and needs that rural families may face when they're trying to access prenatal education, healthcare, all that stuff. Secondly, there is a lack of evidence on the most effective teaching formats. Prenatal education can be delivered in person, through videos, by digital modules, so many ways, but there's very little research that compares all of these approaches to determine which methods lead to the best maternal and infant outcomes. Finally, research on fathers and partners is pretty minimal. Supporting partners can positively affect maternal well-being, birth experiences, and postpartum adjustment, yet their educational needs remain underexplored. Identifying these gaps highlights the importance of continuing research in prenatal education, especially in rural settings, and tailoring programs to meet the needs of both mothers and their families. We think that future studies could examine different delivery formats in rural Virginia to determine which approaches most effectively support maternal mental health and postpartum outcomes.
Keeping in mind the identified gaps in research that we've identified, there is a lack of local data surrounding prenatal education and its effect on postpartum outcomes. For future research, we would propose starting right here in Harrisonburg, firstly by reaching out to local OBGYN offices and assessing if they provide evidence-based prenatal education classes. If they do provide these classes, we would then provide surveys for patients to fill out throughout the pregnancy when they are taking the class and also postpartum, so we can assess how they felt going into childbirth and after childbirth. Ideally, keeping in mind some of our studies assessed women in multiple times throughout the postpartum period, we would also want to incorporate that here so we can get some adequate reflection.
In closing, a bump in the road highlights how even small challenges can create opportunities for learning, reflection, and growth. By examining what went wrong, what could have been improved, and how we can better support patients moving forward, we strengthen not only our clinical judgment, but also the quality of care that we provide. Thank you all for listening, and we appreciate your time and engagement. And this is a time for questions.
What led you to choose this topic? Do you want to go first?
I had the most wonderful clinical experience with Hannah. I wish you could be here. But yeah, I got to go, well, me and Caitlin, I think Riley too, got to go to Huga, and it's a wonderful place. I would suggest going there as a patient. But yeah, I just really love the maternal side, and then also I'm going to go into the NICU, so obviously I love the babies too.
For me, when I was doing my ER clinicals, there was a baby that was brought in, and they believed it was an accidental suffocation type thing. And to me, that just really showed me how powerful education really is.
For me, it's very similar to Taylor. I just loved Huga and knew I wanted to partner with them. They really do so much for our community, and I just wanted to be a part of that. And also, I do plan to go into labor and delivery eventually, so yeah.
I don't plan to go into labor and delivery eventually, but other than the class with Hannah, OB, and the short clinical rotation we did, I don't know a ton about it, so I just thought I might as well get educated on it.
Any other questions? She has the mic. So.
What was the information on some of the handouts that you guys made?
So we had a variety of handouts. Some of them were postpartum educational resources, which were mentioned in the presentation, like gestational diabetes, immunizations, lifestyle things for postpartum. And then we also had kind of just not related to postpartum was PCOS.
Tobacco.
Diabetes, type 2 diabetes.
Yeah.
Tobacco cessation.
Yeah. So yeah, Hugo just kind of identified needs that they need, and yeah, Hannah's been using them to hand out to patients.
She's not coming to you, Wendy.
Thank you so much. I learned a lot from that presentation. You talked about, and also I feel fairly convinced of the importance of prenatal education, not to negate the value of further research, but you mentioned some of the barriers present locally, transportation, our multilingual population, and cost, which I would hypothesize are probably prevalent in a lot of areas. So long term, certainly working on reducing these barriers would be of value, but I'm wondering either from your experience in talking with providers at Huga or just from your own perspective, how can the disparity, the prevalence of, women who receive, pregnant people who receive prenatal education, that disparity be reduced before these barriers, before solutions are found for these barriers? So taking into mind the population that has limited transportation, our multilingual population, and the cost, how can we still reduce disparities in prenatal education?
I think Harrisonburg luckily has a lot of other resources that I think incorporate maternal and infant care. I think a lot about my clinical at the health department. They do a lot as well, a wide variety of things that really help moms and babies. So I feel like we could start there at those places to help negate those barriers. There's also HCHC. Mm-hmm. HCHC as well does a lot of similar things as the health department. So I feel like we could start within those two places, figure out what they do to help aid in prenatal education, and just go from there. I feel like it just starts, you have to start small,
Mm-hmm.
I think it also starts making it known that there is a barrier issue, because I think that's kind of yes, there's barriers, but we kind of skip over, and there's anyway, here we go, here's prenatal education. So simple things like advertising, we have this, we know you might not be able to pay for it, or transportation, but the handouts for Huga, that was part of recognizing a need. And the handouts, if we had much more time and things like that, they talked about having handouts in a variety of languages, having them, we have printed forms that they're handing out, but they also, I think, are emailing them to people that don't want a physical copy. So yeah, just kind of giving the education in all forms that are available to a variety of people.
Wendy, did you have a question? I saw your hand.
Kind of address.
Gotcha. Okay.
Any other questions? Okay. Joshua, resources side.
Oh, yeah. Here are our, wrong button. Why is it going backwards?
I think it's upside down.
Oh, sorry. Hold on, we'll get there. Here are our resources. Sorry about that.
Thank you.
Thank you again for starting us off with a great presentation. So we have a little bit of a break here while we get ready for our next presentation. So you're welcome to take a bio break if you need it or get up and move around. Just another reminder for our lovely audience, please don't have your phones out during presentations so that you aren't distracted in your attention. So we'll be, and Wendy says sound off. Oh, right, in case you get a notification or something. Yep, please put your phones on silent. Thanks. So we'll be back in about 10 minutes. Thank you. Just a reminder, if you haven't signed in yet, this is a good time to do that. I'm waiting till I don't see phones up anymore. I want you to all get it before Clay takes the slide down. Welcome back. All right. Welcome back. We are ready for our second presentation of the day. Thank you. This presentation is entitled Navigating Mental Health in Individuals with Intellectual and Developmental Disabilities, and it's being presented by Emma Ryman, Caitlin Anderson, Noel Paraquo. I just thought about it too hard, didn't I? And Nishay Dixon. So would you please join me in welcoming them to the stage?
Good morning. My name is Noelle.
I'm Emma.
I'm Caitlin.
I'm Nishay.
And today we'll be navigating mental health in individuals with intellectual and developmental disabilities. At the end of this presentation, you will be able to describe the meaning of IDD in 1 to 2 sentences, list at least 3 mental health barriers commonly experienced by individuals with IDD, identify at least 2 ethical dilemmas related to research and medication use involving the individuals with IDD, discuss at least 2 opportunities for improving mental health services for individuals with IDD, and explain 2 to 3 nursing interventions that can be applied to improve mental health outcomes in individuals with IDD.
Before we get started, let's have a discussion to get us thinking about our topic. Please raise your hands if you have heard the acronym IDD before today. IDD stands for Intellectual and Developmental Disabilities. We reference this acronym throughout the presentation, so we would like to ensure that everyone understands who we are talking about. Over the next minute, you can discuss with the person sitting next to you or reflect to yourself the discussion questions stated above and reflect on them throughout our presentation. We will have a reflection at the end of the presentation for you to discuss.
Alrighty, we'll come back now. So today we'll be discussing the mental health challenges and disparities faced by individuals with intellectual and developmental disabilities, or IDD, and the critical role nurses play in addressing these issues. Nurses continue to rank as one of the most trusted professions in the United States, with 78% of adults recognizing the honesty and ethical integrity of nursing professionals. This level of trust highlights the vital responsibility nurses hold in promoting health, alleviating suffering, and supporting the vulnerable populations. Through the constant delivery of compassionate, patient-centered care, nursing demonstrates a unique combination of scientific expertise and empathetic practice, which is essential for enhancing the well-being of individuals and communities. The integrity of nursing in modern healthcare is strongly tied to its use of evidence-based practice, or EBP. According to Brunt and colleagues, EBP is defined as a systematic approach that integrates the strongest research evidence, clinical judgment, and patient values to improve health outcomes. By combining empathy with research-driven strategies, nurses can make informed decisions that enhance patient safety, quality, and overall outcomes. This approach is particularly important when working with populations that face significant health disparities, such as individuals with IDD.
These individuals experience lifelong conditions that influence their thinking, learning, behavior, and in some cases, physical development. Intellectual disabilities are present before the age of 18 and involve challenges with reasoning, problem solving, and cognitive functioning, as well as difficulties managing daily life tasks and social interactions. Developmental disabilities include a long-term physical, cognitive, or combined impairments, and when both intellectual and other developmental impairments exist, the term IDD is used. Friedman and colleagues' research indicates that approximately 40% of individuals with IDD also experience a mental health condition, with anxiety and depression being the most common. Despite this high prevalence, mental health care for people with IDD is often insufficiently addressed due to communication challenges, systemic barriers, stigma, negative attitudes, and improper medication use. Evidence-based interventions adapted for this population, such as cognitive behavior therapy and behavioral activation, have been shown to improve mental health outcomes by addressing both individual and systemic barriers. For our project, we partnered with Pleasant View, a nonprofit with services throughout Harrisonburg and Rockingham County. Pleasant View supports adults with intellectual and developmental disabilities and focuses on promoting holistic health, independence, inclusion, and community connection. This organization offers residential services, day support, employment assistance, transportation, and spiritual care. Our work with the agency Pleasant View has provided practical insight into these challenges. By observing and collaborating directly with individuals with IDD, we have gained a clearer understanding of the barriers they face in accessing mental health services and the strategies nurses can use to provide meaningful support. This experience highlights the importance of applying evidence-based, person-centered approaches in real-world settings to improve mental health outcomes and overall quality of life for this vulnerable population. Through our time at Pleasant View, it was clear that residents have diverse whole health needs, including mental health support, coping skills, physical activity, healthy diet education, and chronic disease management. While we could not address everything, our interventions centered on mental health and healthy coping strategies, while incorporating elements of physical activity, nutrition, nature, medication, and strengthening coping skills and promoting healthy habits can overall improve the well-being, and healthy lifestyle habits can also positively influence mental health. In this presentation, we will explore these mental health disparities in depth, discuss the ethical and clinical considerations for care, and provide practical nursing interventions that can be applied to enhance care for individuals with IDD. Our goal is to empower others to address these disparities and advocate for equitable, compassionate, and effective mental health care.
People with IDD face major communication challenges in mental health care. Cashin and colleagues really highlights this. One of the biggest findings from their study was that nurses often didn't know where to start when communicating with patients with IDD. Some even used phrases like, "I don't know where to begin," which shows how unprepared they felt. Because many individuals with IDD use different communication styles like gestures, limited verbal expressions, and assisted devices, clinicians need adapted approaches. But the study showed that these supports aren't often provided. Without communication tools or training, patients can't accurately explain their symptoms, emotions, or concerns. This leads to misunderstandings, misdiagnoses, and incomplete assessments. So the barrier isn't just about the patient's ability to communicate, it's about the system not giving clinicians the tools and time needed to support meaningful communication. Even when a clinician wants to communicate better, the environment they work in make it almost impossible. Cashin and colleagues also found that fast-paced clinical settings are a huge barrier. Mental health assessments require time, patience, and flexibility, but many healthcare spaces are rushed and focused on efficiency. Nurses reported that because things move so quickly, they often rely heavily on caregivers to explain what the patients need. While caregivers can be helpful, it means that the patient's own voice is often not heard. Clinicians also mention feeling unsure or afraid of saying the wrong thing, which leads to rushed assessments or avoiding certain questions altogether. So even though communication is the main issue, the real problem underneath is that the clinical environment is not being designed to support patients with IDD. Without time, training, and slower-paced assessments, important mental health needs get missed. Another major barrier comes from the healthcare system itself, especially when people with IDD move from pediatric to adult services. Marizian and colleagues interviewed caregivers, clinicians, and agency staff, and they all described how complicated and broken the transition can be. Many young adults suddenly lose services they've relied on for years because the eligibility rules change. There's also poor coordination between pediatric providers and adult providers, meaning families are left to figure out everything on their own. The study reported long wait lists, inconsistent policies, and really limited communication between systems. Even when the patient has a good treatment plan, these systemic issues cause gaps in follow-up care, delays in mental health services, and lots of confusion for families. So this shows that mental health care for people with IDD isn't just affected by clinical skills. It's heavily shaped by the structure and organization of healthcare systems. The final major barrier is stigma, which comes directly from provider attitudes. Lagu and colleagues found that many clinicians feel discomfort, low confidence, or even negative expectations when working with patients who have IDD. These attitudes aren't always intentional, but they still affect care in big ways. One of the strongest findings was that providers often spend less time with patients with IDD. Shorter appointment times led to rushed evaluations, missed symptoms, and less discussion around mental health concerns. Some clinicians even avoided working with this population because they felt unprepared or lacked training. When providers start with the mindset that a patient is too difficult or won't understand, the care automatically becomes lower quality. This kind of subtle stigma can be just as harmful as any structural barrier because it directly affects the patient's experience and outcomes. So addressing stigma and improving provider expectations is essential if we want people with IDD to receive equal access to mental health care.
Now that we've talked about the barriers individuals with IDD face trying to access mental health care, I'm going to walk through evidence-based interventions that directly address some of these challenges. One of the strongest evidence-based approaches for improving mental health in individuals with IDD is modified cognitive behavioral therapy, or CBT. Multiple randomized control trials show that CBT works when sessions use visuals, repetition, structured worksheets, and simplified language, which help overcome communication and cognitive barriers. The first study by Hayudis and colleagues tested modified CBT over 16 weeks with adults who had IDD and symptoms of anxiety and depression. Even though it is an older study, it remains foundational because it was the first randomized controlled trial to test adapted CBT in this population, and its structure is still what modern studies build on today. This study showed a 6.5-point reduction in symptoms compared to 2.1 points in treatment as usual, suggesting clinically meaningful improvement. A second study by Cooney and colleagues expanded access through computerized CBT using visual supports, narration, and simplified content. The participants improved more than twice as much as the control group. Another study by Jehoda and colleagues showed that adapted behavioral activation, a more behavioral-focused approach, also reduced depression when interventions are structured and reinforced by caregivers. The consistent message across these studies is that therapy must be adapted in a way that reduces cognitive and communication barriers, which is the approach we used at Pleasant View.
Lewin's change theory helps us understand how to guide a community through a planned health change. It has three main phases. The first is the unfreeze phase, where we prepare a community by raising awareness, addressing concerns, and building motivation to change. The second is the change phase, where new behaviors, programs, practices are introduced and supported. And the final phase is the refreeze phase, where the new changes become part of the community's normal routine, reinforced through education, resources, and ongoing support. This model helps ensure that health improvements are not only adopted but also sustained over time. Throughout our interactions with Pleasant View, we were able to effectively model Lewin's change theory. During our initial visits, we focused on building trust and getting to know the clients and staff. We took time to understand their concerns, daily challenges, and their reasons for mental health struggles many of the clients were experiencing. We also made and collected surveys which helped us better in the assessment process. This assessment phase helped us identify priority areas and guided the development of our mental health focused interventions and daily activity topics. This is what took place during our unfreeze phase. The second step was the change phase. Once we had a clear understanding of their needs, we began implementing our planned interventions and activities with the support of the Pleasant View staff. We introduced new strategies aimed at improving mental well-being, engagement, and emotional expression. And the third step was the refreeze phase. And in this final phase, we ensured that the changes could be sustained after our departure. We left the staff with materials, instructions, and guidance so they could continue integrating these activities and interventions into the client's regular routines. This helped solidify the new practices and promote long-term benefits for the Pleasant View community.
To apply this research into practice at Pleasant View, we implemented several adapted CBT-aligned interventions that aim to reduce communication, coping, and self-regulation barriers. Our starting point was the mental health survey we conducted, asking questions like, when you feel stressed, what helps you calm down, or what do you engage in when you feel stressed or upset? For the individuals who could not verbally respond, caregivers answered for them because they know them the best. This helped us guide our interventions within the unfreeze phase of change theory and what to do next. The majority of the responses to the questions showed unhealthy coping mechanisms and lack of knowledge of non-pharmacological interventions, such as healthy eating, exercising, and etc. This matches the CBT principle of identifying automatic responses and existing coping strategies, similar to the assessment phase in Hyotis and colleagues. Next was our Healthy Eating Day. This activity used printed pictures of healthy and unhealthy foods, allowing participants to choose items they typically enjoyed or used for coping. After reviewing their initial selection, we provided education on healthier alternatives and how different foods can impact mood and mental health. With this teach-back approach, using visuals, categorization, and repetition, we helped reframe their coping habits by connecting food choices to emotional well-being. The outcome was positive, as most participants selected healthier options during the second round, reflecting a CBT-style cognitive restructuring where new information leads to healthier decisions. Next was our Nature Day that consisted of planting seeds, watering soil, and engaging in a sensory-rich outdoor activity aligned closely with behavioral activation. The individuals re-engaged in calming, meaningful tasks that increased positive emotions. Within these two activities, the change phase was demonstrated to improve mental health of the individuals at Pleasant View. I also want to highlight how nursing interventions fit into reducing these mental health barriers. Nurses play a key role by first assessing communication needs and emotional literacy, which helps us determine how individuals express distress or anxiety. A major nursing focus is collaborating with caregivers because they often know the individual's baseline behavior and can help reinforce skills outside of the intervention time. Nurses also teach and model simple, accessible coping strategies such as deep breathing and grounding techniques. Modifying the environment to reduce overstimulation directly supports the individuals who struggle with sensory processing. Overall, these interventions strengthen their ability to identify feelings, choose adaptive coping strategies, and engage in activities that improve moods. By adapting education, using visuals, modeling, and collaborating with caregivers, we were able to apply research-supported strategies in a way that the individuals could understand and enjoy.
When collecting data or providing treatment for people with intellectual and developmental disabilities, there are several ethical issues we need to be aware of. One major challenge involves informed consent. Forcha and colleagues explains that many individuals with IDD may not fully understand research procedures or risks, which means there's a higher chance of unintentional coercion or misunderstanding compared to the general population. This raises the question, can the person truly consent on their own? And if they cannot, how do we make sure that their rights are still protected? Researchers must use simplified language, visual supports, and check for understanding, and when needed, involve legal guardians while still respecting the person's autonomy as much as possible. Another ethical dilemma involves conducting clinical trials with this population. Because of the increased vulnerability and difficulty communicating discomfort, it can be seen as unethical to expose individuals with IDD to experimental treatments unless safeguards are extremely strong. This makes researchers question whether the potential benefits truly outweigh the risks. Beyond research, there are everyday ethical issues in clinical practice, especially around overmedication. Many providers may unintentionally overprescribe psychotropic medications to manage behaviors like agitation, aggression, or self-harm. The concern is that the medication may be used as a form of chemical restraint rather than actual treatment. This creates a conflict with multiple ethical principles. Nurses play a huge role here. Nurses can uphold ethical principles by advocating for least restrictive interventions, monitoring side effects closely, ensuring informed consent is meaningful, and questioning whether medications are used because they're clinically necessary or simply convenient. Nurses can also educate families, encourage interdisciplinary communication, and make sure that the patient's preferences and behaviors are understood rather than automatically medicated. Overall, the ethical dilemmas around consent, research participation, and medication use remind us that people with IDD deserve the same dignity, rights, and thoughtful decision-making as any other patient. It's our responsibility to ensure protections are in place and that their care is guided by ethical practice, not convenience.
Now that we have introduced some of the ethical dilemmas involving this population, let's take a look at one of the larger ethical barriers. Despite the high prevalence of mental health diagnoses among individuals with intellectual and developmental disorders, there remains a notable lack of research examining the use and effects of psychotropic medications, particularly antipsychotics and antidepressants within this population. Individuals with IDD are prescribed antipsychotic and antidepressant medications at much higher rates than the general population. Many of these prescriptions are off-label and used to manage challenging behaviors rather than diagnose mental health conditions. However, research on the safety, efficiency, and long-term impact of these medications in IDD populations is extremely limited. This lack of evidence increases the risk of serious side effects such as metabolic issues, movement disorders, and sedation, contributes to overmedication or polypharmacy, and leads to the use of medications when behavioral or environmental interventions might be more appropriate. When researching or prescribing psychotropic medications for individuals with IDD, there are several major ethical issues we need to pay close attention to. One of the biggest challenges involves informed consent. Because psychotropic medications come with complex risks like metabolic changes, movement disorders, and emotional blunting, understanding those risks is crucial. Yet many individuals with IDD may have difficulty fully grasping side effects, long-term consequences, or the purpose of the medication. Researchers such as Fortia and colleagues emphasize that limited understanding increases the likelihood of unintentional influence or misunderstanding, especially when a person wants to please caregivers or avoid conflict. This raises an essential question. Can the IDD individual truly consent to psychotropic medication or research participation on their own? And if not, how do we ensure their rights and autonomy is respected? Another ethical dilemma involves including individuals in IDD in psychotropic medication research and clinical trials. Because this population is more vulnerable to side effects and may have difficulty expressing discomfort, research often hesitate to include them in trials of new antidepressants and antipsychotics. The fear is that it may be unethical to expose them to experimental treatments unless extremely strong safeguards are in place. However, this creates a difficult tension. When individuals with IDD are excluded from research, they still end up receiving these medications in clinical practice, but without evidence to guide safe dosing, monitoring, and expected outcomes. So researchers and clinicians must ask, do the potential benefits of developing evidence-based care outweigh the risk of involving a vulnerable population in psychotropic studies? Beyond the research, there are significant everyday ethical challenges in clinical practice, especially around the risk of overmedication. Psychotropic medications are frequently used to manage behaviors such as agitation, aggression, or self-injury, even when these behaviors may be in response to pain, unmet needs, environmental stress, or communication barriers. This raises the concern that psychotropics can become a form of chemical restraint rather than treatment for an actual mental health condition. This situation conflicts with multiple ethical principles. Autonomy is affected when individuals cannot fully express their preferences or advocate for themselves regarding medication use. Non-maleficence or do no harm is challenged when antipsychotics or antidepressants are used without adequate monitoring or clear clinical Justification. Beneficence becomes complicated if medication is used mainly to reduce behaviors for the convenience of staff rather than to improve the person's well-being. And justice is threatened when individuals with IDD are more likely to receive medication instead of non-pharmacological supports like therapy, communication interventions, or sensory regulation strategies. Nurses play an especially important role in addressing these ethical dilemmas. They are often the ones who observe daily behavioral changes and medication effects, making them essential advocates for ethical psychotropic use. Overall, the ethical challenges related to informed consent, research involvement, and the use of psychotropic medications highlight the need to treat individuals with IDD with the same dignity, rights, and careful consideration as all other patients. As healthcare professionals, we have a responsibility to uphold strong safeguards and ensure that every treatment decision is grounded in ethics, evidence, and genuine respect for the person, not simply convenience. To better understand how these ethical issues play out in real-world practice, it is important to look at the current research on psychotropic medication use in individuals with IDD. The ethical concerns surrounding informed consent, potential overuse, and the risk of adverse effects are not just theoretical. They are reflected in the data. By examining both recent and older studies, we can see clear patterns in prescribing practices, the frequency of side effects, and the gaps still that exist in the evidence-based care. The following research analysis illustrates how the ethical dilemmas emerge in clinical settings and why ongoing study is essential to ensuring safe, equitable, and appropriate treatment for individuals with IDD. In 2025, Marquise and colleagues conducted a large retrospective cohort study examining how often youth with IDD were prescribed antipsychotic medications compared to youth without, as they transitioned from pediatric to adult health services. They also looked at differences across specific types of IDD, including autism, fetal alcohol spectrum disorder, and Down syndrome. To do this, they used 10 years of health data from British Columbia covering the period from 2010 to 2019. Their sample was very large, over 20,000 youth with IDD and more than 1.2 million youth without, all between the ages of 15 and 24. The data came from multiple population-level sources, including demographic records, physician billing information, hospitalizations, income data, and pharmacy dispensing files. What Marquise and colleagues found was concerning. Youth with IDD were significantly more likely to be dispensed antipsychotic medications even when they did not have a diagnosis of a psychotic disorder. Many of these youth were receiving these prescriptions at relatively young ages. These findings raise clear ethical concerns, especially when we consider the long-term risk of antipsychotics, like weight gain, metabolic syndrome, and type 2 diabetes. The study suggests a pattern of overuse and raises the possibility that medications may be used as a default intervention rather than exploring safer behavioral and environmental approaches. These concerns are supported by an older study conducted by Shifas and colleagues in 2016. Their study focuses on adults with IDD living in 3 Dutch inpatient treatment facilities, all of whom had mild to borderline IDD and severe behavioral challenges. They included 103 adults who provided informed consent, and they collected information from medical records, standardized cognitive assessments, pharmacy systems, and physician evaluations. Psychiatrists and IDD specialized physicians assessed adverse events, and quality of life was evaluated through both the patient and the clinician reports. Shifas and colleagues found that almost half of the participants, 45.6%, experienced 3 or more adverse events related to their psychotropic medications. Some of the most common issues included psychological changes, sleep problems, fatigue, weight gain, and neurological symptoms. These results highlighted just how heavy the burden of side effects can be for individuals with IDD, especially when medications are used long-term or in combination with other drugs. Now, both studies do have limitations. Marquise and colleagues worked with a very large sample, but administrative data can miss important details about clinical decision-making. Shifas and colleagues had a much smaller sample, but their study is almost a decade old, meaning some findings may not reflect current medication practices. Additionally, both studies were conducted outside the United States, so there may be differences in healthcare systems and cultural attributes that affected how well the results apply here. However, despite these differences, both studies reached similar and important conclusions. They show clear evidence that psychotropic medications are used more frequently among individuals with IDD than those without, and they demonstrate that adverse effects are common and can be clinically significant. These findings raise major ethical concerns related to autonomy, beneficence, non-maleficence, and justice. Together, the research underscores the urgent need for rigorous, inclusive, and current studies to guide safe, ethical, and evidence-based psychotropic prescribing practices for individuals with IDD.
Next, I want to explain how our interventions also connect to some of the medication-related challenges Caitlin discussed. One of the core findings of Jehoda and colleagues was that structured behavioral activities reduce depressive symptoms even when individuals also take medication for emotional regulation. But evidence shows that engaging in meaningful activity can reduce mood instability and improve functioning, lowering the need for medication changes or crisis PRNs. Activity-based interventions, like the ones we use at Pleasant View, directly support medication management by helping the individuals regulate their mood and behavior through non-pharmacological strategies. At Pleasant View, 2 of the interventions we did specifically supported mental health in ways that complement medication. Physical Activity Day included dancing, singing, music, a balloon paddle game, with every participant actively joining in and especially enjoying the balloon paddle game. At the end, when asked whether they had fun, all individuals reported that they enjoyed the game and felt happier. This session supports the principles of behavioral activation by increasing positive reinforcement and reducing social withdrawal. Physical activity also helps address challenges related to medication use by reducing restlessness, improving sleep, stabilizing mood, and lowering anxiety, ultimately decreasing the reliance on medications for emotional regulation.
Now we invite you to participate in one of the activities that we used as one of our interventions at Pleasant View. With your surrounding neighbors, try to keep these balloons off the floor while remaining in your space.
Wish I could take a picture.
All right, we ask everybody to wrap up the activity. I hope everyone enjoyed that nice, physically active mental health break. Now we ask you to reflect on your own. How might you have to adjust this activity for individuals with IDD?
Our next activity was the meditation session, which was designed for individuals with higher support needs and included calming music, range of motion exercises, lotion-assisted stretching, tactile balloon activities, and reading. Although participants could not verbally provide feedback, we observed positive responses such as smiling, laughter, and active engagement, and decreased agitation. Staff also reported that the individuals enjoyed the session so much that they requested an additional day for the intervention to be implemented. These responses reflect the behavioral activation principle of using sensory grounding to regulate mood, and especially meaningful approach for individuals on multiple medications, as these non-pharmacological interventions can help reduce behavioral escalations that might otherwise lead to medication adjustments. Along with the activity-based interventions, there are also nursing-specific strategies that help manage medication-related challenges. Nurses monitor for side effects, mood changes, sleep disturbances, or increased agitation, which is especially important for individuals who have difficulty verbally communicating discomfort. Nurses can also provide simplified education on the purpose of medication, using visuals, prediction, or supported explanations to increase understanding. Nurses can also ensure that informed consent is meaningful and ongoing, facilitating interdisciplinary communication so decisions are carefully considered rather than automatic. Another essential nursing role is promoting non-pharmacological coping strategies like the ones we use at Pleasant View, so medication is not the only tool used for regulation. Overall, activity-based and sensory-based interventions help stabilize mood, reduce agitation, and support emotional regulation, which complements medication therapy. By doing this, we were able to show that adapted behavioral approaches, including CBT-based education, behavioral activation, and sensory grounding, are effective ways to support individuals with IDD in managing mental health challenges.
So overall, these barriers show that people with IDD aren't struggling because of their disability alone. They're struggling because of the system, the environment, and even provider attitudes haven't met their needs. Communication challenges, rushed clinical settings, broken transitions, and stigma all work together to limit access to quality mental health care. If we want real change, we have to focus on better communication tools, more supportive environments, smoother transitions, and reducing stigma. When we do that, people with IDD can actually get the equitable care they deserve.
Together, the ethical concerns, research findings make it clear that psychotropic medication use in individuals with IDD requires a much greater scrutiny, transparency, and clinical care. The challenges surrounding informed consent, vulnerability, and the risk of medications being used as the substitute for individualized behavioral supports are directly reflected in the data showing high prescribing rates and significant adverse effects. Both the newer and older research demonstrate consistent patterns of overuse and highlight the physical, psychological, and quality of life consequences these medications can have when not carefully monitored or justified. The insights emphasize an urgent need for more inclusive studies, better guidelines, and stronger advocacy to ensure that treatment decisions genuinely promote the well-being, autonomy, and dignity of individuals with IDD. Ultimately, safe and ethical psychotropic prescribing depends on ongoing research, interdisciplinary collaboration, and a commitment to person-centered care.
All of these interventions gave participants skills and experiences that support both their mental health and their medication management. And important, they were rooted in strong evidence, but implemented in a way that was meaningful, accessible, and enjoyable to the residents at Pleasant View.
Thank you all for listening to our presentation. At this time, we ask you to reflect back on the questions asked at the beginning, and we also open up the space for further questions as well.
What was your favorite part of your project, like at Pleasant View?
Mine was the balloon activity. Everyone was engaged. It was like a dancing day. I semi-choreographed a dance that everyone participated in, and yeah, that was my favorite. There was no pictures that day. Oh, sorry.
Mine was getting to know the individuals. We spent several days at the beginning of our project just going and meeting with them and getting to know what they liked, which helped develop our interventions and what they wanted to do.
I think mine was also the physical activity day from the balloon intervention, as well as just other movement things, but I also really enjoyed the nature day, getting to pot little plants and seeds. That was really fun.
Mine was the nature day. It got a little messy, but it was so much fun just teaching them how to pot plants. And we got to take one home, and mine is really sprouting, so I hope theirs is too.
Hi, so I'm curious, when you first started your project, if you can reflect back, knowing what you know now, what would you have done differently or done sooner or done in a different way when you were assessing the need for the project plan and the interventions you eventually developed?
I would say that a lot of times we would go in with a plan and it would have to be adjusted according to the different needs for the different individuals, and we tried, I think, pretty hard before to have activities that could fit a lot of different physical needs and developmental needs, but you still always had to make adjustments. And I think going back now, and the more you get to know the individuals, it's easier to understand some of those needs and how to best adapt. But at the beginning, we were kind of going in blind. I mean, we tried to get to know people for the first few days, but it was hard to find ways to tailor the activities to fit all the needs.
Your reflection question, what mental health community resources have you heard of that support individuals with IDD? Did you see any that they implemented at Pleasant View? Like, did they have opportunities to deal with that?
So when we went in and we had not really decided on this topic, we kind of went in with letting them decide what they wanted us to do. And they specifically asked for this, in a broad range, they needed quite a few things to help with, but they specifically were like, we don't have a lot of community resources. So trying to implement interventions that they can do for themselves and then connecting them with the community is how we went about that.
I noticed that most of your resources were pretty up to date, but there was a 2011, which was pretty outdated. I was wondering, was there something special about that resource that you really liked?
Yeah, so I used that one because when I was researching more up-to-date modified cognitive behavioral therapy studies, all of them reference back to that one specific study because it was the first randomized control trial that used CBT. So it was just easier, instead of using all the other ones, just use the main one that they're all referencing back to.
And for others who have high functioning autism, which typically gets undershed, how could you say that one can advocate for themselves? Because typically they look pretty well presenting, but they're actually struggling within the system. And if they have professors or other faculty saying, equality this, equality that, but they're actually suffering inside, how would you say they could advocate for themselves?
I think that comes down to really spending time and getting to know and doing personalized care interventions and using what they want and integrating them. Like, we had to adjust for each individual. So that individual, you would have to really dedicate the time to being able to adjust their interventions to their needs. And it might take a little bit longer than like in a hospital setting or something like that.
Also at Pleasant View, they were really big on the autonomy of all the residents, even if they were higher functioning, lower functioning support needs. Questions were still asked, choices were still made for the residents themselves.
All right, thank you so much for a wonderful morning. As you will note on your schedule, we have a pretty long lunch break, and that's because there are a number of really wonderful things for you to do over the lunch break, and we want you to have time. So first and foremost, there is a career fair just outside of this room with 6 local employers. Those of you who are nursing students can talk to them about future job stuff, about internships or externships, even if you're not graduating in the next year, or just sort of have some practice with what it feels like to talk to a job recruiter from a healthcare organization. So we strongly encourage you to interact with them. Also outside of these doors, we have some excellent toy projects that were designed by level 2 students in Holly's PEDS class that were so wonderful we wanted to share them broadly. So please stop by the toy tables. They're just over here to my left, your right. And it's almost Thanksgiving. It's Thanksgiving Day in the CAF, and you can all pick up if you'd like to eat, have a free meal in the CAF. Sam at the back has tickets, so you can have a free meal. It's usually a little crowded, so give yourself a little extra time there. We will see you back here for the final presentation, which will start at 1:30, so please be back here about 1:20. Thanks. Have a great lunch.